This week on the BackTable podcast.
I think one thing moving forward, other than more otolaryngologists who see children sort of recognizing it and maybe starting to be able to integrate it into their practice, because as it becomes, more popular on the education front, talking with other people who do this across the country and seeing the need and wanting to sort of share with our colleagues to sort of make this a more common practice. We're going to try to do, panels at our major meetings. There's even a very preliminary thought about now that we have like simulation and 3D models being very easily accessible, having like a newborn ear model just to practice applying the molds on, just because it could be sort of daunting to do it on your first patient. So those are some things that could be coming up.
My name is Gopi Shah. I'm a pediatric ENT, and we have an awesome guest today. I have a fellow pediatric ENT, so y'all know I get super excited about that. We have Dr. Jason Qian. He's a surgeon scientist at the University of California, San Diego. He's a pediatric otolaryngologist practicing at Rady Children's Hospital, and he's here to talk to us about ear molding in infants. Welcome to the show, Jason. How are you?
I'm good. Thank you so much for having me, Gopi.
I'm so happy to have you. This is actually my first in-person, in-studio episode for ENT, and it's a pleasure to have you on as our first guest in person.
Yeah, this is super exciting. Never been on a podcast before, and to have to be live here with you, it's really exciting.
Awesome.
I'm honored to be here.
Awesome. Well, thanks for coming on. Can you first tell us a little bit about yourself and your practice?
Yeah. So. Thank you for the introduction. Again, I'm Jason Qian. I'm in my first year after fellowship, and I spend 50% of my time trying to start a translational research lab at UCSD where I study the immunogenetics of chronic otitis media. And then my other 50% of my time I dedicate to my clinical practice at Rady Children's Hospital, where Gopi and I are partners.
Yeah.
And I have a special interest in ear. So that includes congenital anomalies of the middle ear, canal, and the auricle. And I'm the first one in my group, our group, that offers ear molding, which is a bit of how this came to be.
Yeah.
And it turned out it's this huge need that I'm happy to fill in San Diego and in our practice.
That's awesome. So in general, can you tell us how you explain what ear molding is? Whether it's to me, remember, I know we were talking about this in the OR when we were together the other day, but how you explain it to whether it's your colleagues or families of, what is ear molding in infants exactly and what kind of deformities is it for?
Yeah. So ear molding is a non-invasive way to permanently correct certain ear deformities or anomalies in infants. And so the idea of how it works is circulating maternal estrogen in the newborn keeps the cartilage soft and pliable. Of course, that aids in vaginal delivery, but we could leverage that to mold the ears into a more typical or desirable shape that could last permanently before that circulating maternal estrogen washes out and essentially the cartilage sets in its shape. And now that wash out typically happens between 2 to 3 months of age. So ideally, we start the ear molding process at before 6 weeks of age, since the process itself can take 2 to 6 weeks of continuous molding. And essentially what it is a molding device is placed on the ear and continuously worn.
Awesome. So before we get into it, how did you get training in this? I mean, I would say it's pretty niche, even within pediatric otolaryngology.
Yeah.
And how did you start to incorporate it into your practice?
Yeah. So I did my residency and fellowship at Stanford, and I had a mentor there, Mai T. Trong.
Love Mai T.
Yes. So Mai T essentially taught me how to do it her way, and her way of custom molding, and we'll sort of get into the different types of molding, is what I based my practice on, the way I do it. And so Mai T is sort of oversees a lot of the ear molding at Stanford. And then there are 2 NPs, Summer and Charlie, who do a lot of it. And I learned a lot from them too. And so with a custom molding technique, it does take, you do have to sort of see many different ear deformities to kind of know how to adjust the mold, but the general principle is the same. So it did take over my residency and fellowship to be comfortable with it. And then when I came into my practice, essentially, it's kind of a funny story. I showed up, and in my first week of practice, I saw that on my Friday clinic, I had a patient referred for ear molding, and he was 3 weeks old. And in the referral, the pediatrician said the father is very interested in ear molding. And I went around clinic to sort of see what supplies we had. And, one of the supplies that I need is silicone putty, which is essentially like the swimming silicone ear plugs. And we didn't have that in clinic. So I went to CVS and just bought it to just have just in case. And I put the ear molds on when I saw that patient in clinic. And when I saw the patient back, the results were really good. Dad was really happy. And so then it sort of was this organic process where the referring pediatricians, I think it was Scripps, they found out, oh, well, he's, offering it, and we didn't really have anywhere to send these kids. And so that group had started sending the patients to me. Then the other pediatrics groups have found out. And so then, there were these inquiries made, and we had to make some adjustments to our clinical workflow to accommodate this practice. And now business is booming.
That's amazing. So it took one patient, one referral, and kind of the word spread.
That's right. That's right.
Amazing.
Yeah. And I think it sort of goes to show, these days, a lot of parenting, as a new parent myself, we're always online looking stuff up. And a lot of these parents, they're with their newborn and they're looking at the ears and they're looking this up, and they know that ear molding is something that exists, and it's something they're bringing to the pediatricians, and the pediatricians are kind of desperate to see who they could refer to. And so it is something that, a lot of us don't get in our traditional training pathway, but it's something that's becoming more desirable and something that I think a lot of people can integrate into their practice.
Yeah. So when families come to you, like, for example, the dad that came with this baby, what kind of concerns or how do they, what kind of symptoms, what kind of concerns do they have? I think of, in terms of specific deformities for ear molding would be like, quote, cup ear, stall ear, all those sort of buzzwords. But what are the families telling you? Yeah,
so to sort of address 2 points, the families, they're really concerned eventually about the psychosocial impact. They're like, it's usually these otherwise well kids, and the ears, they don't have a typical appearance, just say both of them. Sometimes it's just one doesn't match the other, and they're really afraid of bullying in the future. That's like this, as a new parent myself, that's something I sort of project into the future. And if there's, something like the ear is looking not typical, and they go online and find out that, well, there is an option for not surgery, a non-invasive option that could just sort of fix this problem for life. A lot of parents come looking for that to sort of prevent any potential future psychosocial issues.
Yeah. And you said that this is, obviously presents very early. Have you ever gotten a referral for an ear deformity that was found on prenatal ultrasound? Or have you ever been consulted, whether it was in your training or in practice, to the NICU or the newborn nursery for ear molding?
Yeah. So about the ultrasound question, the ears are not typically looked at in a typical 20-week anatomy scan. But if there are concerns on the 20-week anatomy scan and they follow up with craniofacial investigations, you could see auricular anomalies, but usually they have to be a more major anomaly like microtia, where there is this absence of skin and cartilage, whereas a lot of the ear molding deformities, what is moldable are malformations in the folding or the shape, but there is no absence in skin or cartilage. And so a lot of times, I would say most times, the ears are not picked up prenatally and it's sort of discovered on birth. The NICU question is a good one too. So most of my patients right now are being referred to by pediatricians from well child visits in the newborn period. The director of the NICU here in San Diego is one of my scientific mentors, and we had talked about this on the side, and she does want me to present, ear molding to the NICU, which I'm happy to do, but that would also open up this other can of worms, which would be inpatient ear molding consults, and that we would have to sort of figure out how to incorporate that workflow into our consult service.
Right. And I guess the other question is there enough volume for that? Or what is the incidence? Just out of curiosity, do we know?
Yeah, well, I'm not actually too sure what the incidence of the moldable ears are, but for me, they're quite high. Pretty much everyone in my every clinic that I have, I have an ear molding patient, and so.
That's amazing. It's one of those where it's like if you build it, they will come, and if you're not looking for it, you're going to miss it. It's right there. It's all around you, kind of in a way.
Yeah, I had a patient who's unfortunately came to me at 11 weeks. So, as I said, This ideally starts at before 6 weeks. And so the patient was referred to me at 11 weeks. And I'm still happy to see these patients. As a lot of times, even to talk about, other options in the future, I begin to offer otoplasty at around age 5. Now, this patient had a stall ear. And so that's kind of one of our buzzwords. And I guess we should also talk about first the deformities that can be molded. Again, it's the ones where there's not a lack of skin or cartilage. So we're thinking prominent ear or promenoris, cup ear, lop ear, the stall ear, helical rim deformities. And so those are moldable, whereas deficiencies of skin and cartilage, like anything on the microtia spectrum, is not moldable. You can't create something, reshape something out of nothing. And so this patient, this 11-week-old patient, had a stall ear, and that's actually a very challenging otoplasty to do in the future. We're sort of taught the traditional, mustarde and Fernas, that sort of shows up on our boards, but that's really for prominent ear. So if you have like a stall bar, which is an extra fold between your antihelix to the helical rim, that sort of unfolds the helical rim, the otoplasty there is you have to cut that out to cut that folded cartilage out. A mustarde suture is not going to do anything for that. And you might have to actually cut out some other pieces of cartilage in order to reform the helical contour. And, it just doesn't, the outcome isn't necessarily that great, whereas molding these stalls bars early enough, the results are so good. Honestly, they surprised me, and I think that was one of the before and after I sent you. A lot of ear molding is about setting expectations, both for the family and for myself. And we keep those expectations pretty low. We're just trying to make it a bit better than it already is, but sometimes it works fabulously well. And so, when I got the referral for the stall ear at an 11-week-old, I was still happy to see and sort of set expectations with moms like, look, I give this less than 30% chance of really doing anything, but I'm happy to put it on. And mom was very, very motivated. And I sort of say this because mom was like, his grandpa's actually a peds ENT and didn't even really notice or recommend anything earlier on. And, that was very frustrating for mom because, we're at a point now where
we're about to miss the window.
Yeah. So ultimately, there was a modest improvement. I would still say this is a stall's ear, but mom was happy that there was a little bit of improvement.
Yeah. So you said that, there is a window and it's within that 2 to 3 months. Ideally, when should you be seeing them? When should the device or, the silicone putty get put on? And how long do y'all keep it on for?
The younger the child is when we put the device on, the better the long-term outcome. Practically speaking, a lot of times our referrals are coming in the first or second week of life. And then by the time I'm able to, the clinic rearranges the schedule to have them added on. I'm seeing them kind of week 3, 4, 5. So there is that kind of practical aspect. The clinic kind of knows that these patients need to see me before 6 weeks. The earlier, the better, if possible.
Just kind of going back to that initial visit, is there anything specific as part of your history? Are there any risk factors that you're asking about, whether it's during the pregnancy or delivery?
Yes, the big thing for me is really the hearing. Like, did they pass their newborn hearing screen? Sometimes newborn ears are sometimes hard to really even to make sense of, like, is this a grade 1 microtia or does it just like look a little bit weird? And if it is on the microtia spectrum, of course, we do want to, and that's a whole nother conversation in itself, but it's really important to capture any sort of conductive hearing loss and intervene early on. But if they're passing their newborn hearing screen, the other thing would be, are there any other big syndromic features that make us concerned? With the microtia kids, I like to make sure that they have a renal ultrasound because there has been an association between renal anomalies and microtia. One of the thoughts there is that the kidneys and the ears, they develop at the same gestational age. And so that's, one of the reasons for the association. Outside of that, family history, although for the ear molding candidates, there's not always a good family history when it comes to like lop ear. A lot of times prominent ear, you could see it in the parents. And then I do an ear exam. I don't know about you though, but like when I do like a newborn otoscopy, I see an eardrum, but it's usually like really floppy and gray, and it's not like I'm seeing great landmarks to begin with. But if you pass the newborn hearing and you have an eardrum, I'm like, you're good for now.
If I can see the posterior team, I'm like, all right, that looks good. We'll take it. Is there any risks associated with like prematurity or traumatic delivery or anything like that, or no? Because this is during the development in utero.
Not that I'm aware of. Even a traumatic delivery, even if your ear is a little bit bent, it's not going to permanently stay there. Our ear molding process, it is a device that has to be worn for weeks. So it would probably be, and we don't really know, but their position in utero, during the development for a long time that caused, certain anomalies. So I don't think it would necessarily be associated with the delivery itself.
In terms of your physical exam, take me through your physical exam, and are you doing photos? Like, do you photo document as well?
That's a great question. The physical exam for these, other than my general newborn ENT exam, if they do have a typical contralateral ear, I'm really looking at that. If the parents have bilateral concerns and we're putting on the bilateral molds, then there's not necessarily one that we're trying to create symmetric. I guess it's kind of similar to how you would think about an otoplasty, but in a newborn. I am actively trying to be better at taking photos because a lot of times you come in, you're starting the counseling, you're examining the baby. A lot of times, like I have the baby on the bed and the medical assistant is holding the head and I just start molding right away. And I've realized like I'm not capturing my before, and so I'm actively trying to improve my photo documentation. But as something we should talk about later is we actually do not have a CPT code for ear molding. And so for reimbursement purposes, you don't really need photo documentation. It should really be more for yourself. And there are some times where there are some parents after you do the ear molding and you're like, this looks really good. And they're like, oh, but it's like a little bit like this. And having that before photo to sort of show them, but it looked like this before.
Right.
So, this result is,
this is great.
I'm very happy with this result.
Yeah.
That's another reason why it helps.
Yeah. Okay. So the babies in your clinic, which babies are good candidates for ear molding, and which babies would you say, you know what, this is something that we can observe, it should get better with time?
I think having one of the obvious more named kind of auricular anomalies are good candidates. And then a lot of times it comes down to the parent motivation. I do now get some patients in my clinic where the pediatrician sent them just because they're like, oh, like the helical rim looks like a little bit flat and I think you should get checked out. And the parents aren't really that bothered by it. And so if the parents aren't bothered, and it is pretty subtle to me because, newborn ears are a little bit weird looking. And unless it's one of those really obvious ones, I tend to, just be really realistic. It's like, well, I think this isn't something we can have a huge improvement on. And if the parents aren't also super motivated, then we're, good to, they're like, I just want to be here to have it checked out, just want to be reassured. And if you don't think there's an issue, we don't have an issue. Those I won't mold. But I would say the vast majority that are coming into my practice are, very parent driven, that like, I've looked this up. This is something I want molded. I'm very concerned about it. And so setting the expectation with parents about what our outcomes are going to be, and then I'm happy to try this with them, and I make no guarantees that it's going to look exactly how they want it to. And most parents, they just want it a little bit better. Yeah. And so it's actually kind of easy that way because you take the molds off, and with most cases, it looks a little bit better or a lot better, and parents are very happy, and they're like, thank you for doing this, and they're on their way. And I always tell them, if you continue to have, if this is something that develops into a big psychosocial issue for the family, I'm happy to see them around age 5, which is when I begin to offer otoplasty.
So that conversation, you mentioned setting the expectations. What is that conversation, whether it's outcomes, actual process? Is there anything that they have to do at home? What's the spiel? Yeah,
so my spiel is that there's no such thing as a perfect ear, right? And so I don't want to say beauty in the eye of the beholder, but there's no such thing as a perfect ear, and that ears are also not perfectly symmetrical. It's unnatural for the ears to be perfectly symmetric. And so what we can do is try to make the ear appear more typical, is what I say, not like appear more normal, just more typical. And there is, again, no guarantee at what our outcome is going to be. We're just going to try to make an improvement on what we have right now while we're still within this window where we could do a non-invasive mold.
And that mold is something that the infant keeps on for 2 weeks, 4 weeks. Do they have to come back? Is there any adjustments, changes?
Great question. So I guess we should talk about the molds themselves. Yeah. And so
what supplies do you need? I imagine you're in the putty right now, but it sounds like there's devices, maybe some silk tape involved.
Yes. So essentially there are 2 major categories of ear molding devices, and one of them is the commercially available devices. And so amongst the commercially available devices, the most popular is the Earwell. And so what the Earwell is a device that the clinic has to purchase from the manufacturer, and it has several parts. So there is a well that is a plastic well that sticks to the skin around the ear. This does involve having to shave the hair of the temporoparietal scalp so that the well can stick there. Then there are small plastic pieces that sort of are fitting on the auricle that do the shaping. So there are ones that retract the helical rim. There are pieces that fit to form the conchal bowl. And then they're all secured with this anterior basket that sort of squishes them into place against the ear and snaps into the well. So after placement of an ear well, you should be seeing the patient every 2 weeks to make sure that, the pieces are still in place. The big risk for ear molding, other than, the risk of not having the desired outcome for the family, is skin breakdown. So any you're checking for skin irritation, ulceration, infection, in which case, of course, you would stop the molding process. But the ear well is worn for 6 weeks, and then everything comes off. Now, the major advantages of the ear well, it's a one-size-fits-most device, and it requires relatively less training and experience to put on. You just sort of follow the instructions, and every ear sort of gets the same treatment, and the outcomes are pretty good. They're very consistent. Now, there is one huge disadvantage of it, and that is that it is cash pay for the vast majority of families. Because there is no CPT code for ear molding, it is very difficult to have insurance reimburse for the cost of the device. And so in our practice at Rady Children's, our clinic doesn't even have the mechanism to charge parents cash for a device. And so a lot of private practices can offer that, but in our practice, we simply cannot offer it. It's not a viable solution. So that's the big downside of that. And there are some other commercially available devices too, but the Earwell is more popular. And so that brings us to this other category of custom-made molding devices, which is kind of a generous and fancy way of sort of saying we are essentially taking supplies that are more readily available in clinic. It's a bit of jerry-rigging and arts and crafts to sort of make these custom molds that we then can place as the molding device. So again, the way that I learned how to do it is modified from my mentor in my training at Stanford, Dr. Mai-T Trong. And so it starts with a piece of wire. And so I get that wire from nasopharyngeal Calgi swabs. So I cut the swab end and the cap end off. And so I have this wire, and it is shaped to the desired contour of the helical rim. Now, I thread that wire then through silicone tubing in order to protect the skin from the metal wire. And so the silicone tubing I actually get from a butterfly needle IV starter kit, because you have the butterfly needle and then you have that kind of frosty silicone tubing. So then I cut the needle off and I cut the end off, and then we have this silicone tubing and I thread the wire through that. That wire is then placed in the scaphoid fossa, so on the inside of the helical rim, to sort of reinforce that rim shape. And I like to dermabond that in order to keep it down. Now, I think like a lot of us have dermabonded ourselves, and it can sting a lot. And so, that stinging is because the dermabond is cyanoacrylate, and it hardens by touching the moisture on your skin and creating an exothermic reaction. So if you're putting it on a cut, that's a lot of moisture, and we're usually putting a lot of burnt dermabond. So that's going to sting. But with an infant's dry ear skin, putting a little bit of dermabond onto that dry skin, really doesn't hurt. So none of this really hurts to the infant. So even a little bit of dermabond is okay in my experience. And so I like to dermabond it to the scaphoid fossa, and then reinforce the shape of it with a silicone putty in order to give the helical rim height. And then in certain deformities like cup ears, so the cup ears, when the conchal bowl can be sort of constricted into a cup, the antihelix is pushed forward. And so with that pushed forward, the lobule can look like it's displaced forward. In those situations, I might put a piece of silicone into the conchal bowl in order to open it and push that antitragus back. So that's where the silicone putty then comes in. And then we have to anchor it with a bunch of tape. And so what I first like to do is to use mastisol and place anchoring tape on the scalp behind the ear. Now, if this is a baby with tons of hair, then that hair has to be trimmed. But in most babies, even a little bit of hair, you could sort of manage it and stick it down with mastisol and then put the steri strips behind the scalp. And then to secure all the putty, I would do radial strips, steri strips, going from the concha or like near the auditory meatus, radially out over everything and adhering posteriorly to the anchoring steri strips. And so that's the general protocol. With certain congenital anomalies, I modify it a bit, like with the Stahl's ear, where we're trying to really shape unfold that stall bar and fold up the helical rim. I might extend the tape to the posterior skin, but in general, that's sort of the protocol.
That's amazing. So with the steri strips, how often do they call to say, hey, it's unfurling, or, the ends tend to unfurl, or it's not sticking? Any concerns with that? Have you faced any problems with that?
Yes, it's a great question, and it's something that's actively evolving. And so what's sort of the follow-up on this? I see them back about every 2 weeks. In order to sort of make it last longer, I do like to use the extra Dermabond and then Dermabond the steris to itself. But then I also tell parents at the 2-week mark, usually it's starting to come off, right? And I always give parents an extra packet of steri strips and tell them to expect it to start coming off in about 2 weeks. And if it starts coming off, we have that follow-up appointment set. You could just put tape over it to reinforce it until I see them, and I also give them that expectation. It can be a lot of work if you're seeing this patient sort of continuously for 6 weeks. It becomes 2-3 visits. But in general, now, I've been seeing the kids for 2 visits, the initial visit and then another visit in about 2 weeks. Sometimes it's shorter, sometimes it's longer. And in that visit, I will take everything off. And the parents will watch me take everything off, so they know, what sort of goes in on it. I'm using either an alcohol swab or one of those adhesive removers, and I gently take everything off. I make parents watch me, and then we sort of decide, do I reapply it? And if I reapply it, I sort of tell them, try to keep this on as long as possible. By that time, they're usually aged past 6 weeks, and so I tell them I'm not going to put another one on, but keep it on as long as you see fit, and then here are some extra steris to reinforce it. But you've watched me take it off, and you could take it off when you're ready. And of course, to kind of let me know if there are any problems with the skin breakdown or anything like that. I haven't had any skin breakdown in my practice. Of course, if there was any, I wouldn't be really putting it on. So in general, I've kind of limited in most cases now to about 2 visits spaced 2 weeks apart.
Got it. So usually the molds, depending on the age that they're put on for, stay on anywhere between 2 to 4 weeks. And this is usually if you can get them into your clinic within that first 2 to 4 weeks of life. Because by the time we're at about 8 weeks, that maternal estrogen we're thinking that was circulating has now been washed out, and this might be the best we get.
Right.
Okay.
Yeah.
Got it. And then if it's like they're 7, 8 weeks and they want to, keep it on a little bit longer, you reapply it, give them that option, and then they can take it off themselves about 2 weeks later.
Correct, yeah.
Okay. And in terms of like ischemia or things like that, are you usually just going to see redness of the skin? Do the babies ever cry of pain? Have you ever had a case of weeping or drainage or seen that before?
I have in my practice and in my training, I haven't seen any major skin breakdown. That, of course, is always the big thing we're worried about. I do give a lot of counseling to parents to be looking at that skin. And parents are usually, very careful about it because while that custom mold is on, they ask a lot of questions. Should they not lay on this side? Should they not do any of that stuff?
Can you not get that side wet during bath time?
Yeah. So I tell them to avoid getting it wet for sure. And so if they do want to wash the hair, it's going to be like with a little sponge. But I think it's really hard to control how that baby is going to, not put pressure on one side and sleep on the other side. But then, you might also have the 2 ear molds. So otherwise, I say just keep it on, keep it dry and as clean as possible, and look at the surrounding skin and let me know if there are any problems. The parents usually have no problems, so I haven't had any complications from skin breakdown. And of course, you have to, I do see them in the 2 weeks to make sure. But the process is really gentle. We do, protect that wire with the silicone tubing. And one of the things when you thread it in is you want to make the tubing a little bit longer than the wire itself so that there's no free ends. And if there's concern for that, I always also plug the ends with the silicone putty. So it's really like silicone putty and tape. It's tight, but it's not so tight that it is causing ischemia. And a lot of times the glue and the mastisol is not even allowing you to make it that tight. And I'm not doing any head wrap or anything like that. So it's otherwise loose enough.
Yeah. And so you mentioned there's no CPT code, so insurance doesn't cover it. In your practice, you're not using a commercial device such as Earwell because you can't really charge for it.
Yes.
You figured out a creative way to get the supplies that you need that sound pretty reasonable. It doesn't sound like anything super expensive here. These are routine things that you're using. How are you billing for it?
So this, I sort of went over how I, by happenstance, started doing this with my first patient. And then I had a lot of follow-up conversations with our finance and billing department. Now, when I had asked my T at Stanford how she was billing for this, she's able to bill the initial visit with the unlisted external ear code, which I believe is 69399, and then her follow-up visits by time. In our practice, I was told we're not allowed to use the unlisted codes. And so there was no CPT code that I can use. And so after discussing this with our finance department extensively, I'm billing E&M by E&M code, and I bill level 5 for time every time. Even though it doesn't take me that long to put the ear mold on, there's a lot of counseling involved in the appointment itself. And then also all of that work beforehand to coordinate urgent care of a newborn and to also have the clinic's supplies, which now, the clinic and the hospital are happy to buy the supplies I need.
You're not going to CVS on your way to work to get silicone putty.
Yeah, they are now ordering the earplugs, which is great. Yeah, so that's sort of how we are pursuing it moving forward, because they were like, we absolutely cannot buy Earwells. Before I got here, there was a purchase of Earwells before that the hospital is taking it as a loss. And they're like, this is just not viable for us to do. So I do have some colleagues. I have a colleague in New York who has had success in getting some of her patients' insurers to reimburse Earwell. So I wouldn't say it's impossible for everybody, but it is not possible in our practice in San Diego.
Do you collaborate with other specialists? I mean, are you doing microtia as well, Jason? Do you find that your colleagues who also, across the states, across internationally, who do infant ear molding, do you have a craniofacial partner or a plastics partner, otologist? Is there a team involved?
Yeah. So with the isolated ear molding, I am, like a lot of cases, if there's no other concerns with hearing or no other craniofacial concerns, it's just sort of a standalone thing. Again, I always offer to these parents, if this is something that you're still unhappy with at age 5, you're happy to come back to see me, and I do otoplasty. And so that's sort of something I'm finding a need within our group that I'm have the training and I'm happy to fill. Most of that conversation is sort of happening for the kids who are beyond the window, who then get referred to me. And so it's more of like counseling. Well, we'll see what happens. There's nothing to do now, but come back to see me. When it does get a bit more complicated, like microtia, I do collaborate. And so I do the hearing for microtia. So, that's a whole nother conversation, because with the microtia, that's an external ear issue, but we very often comes with canal and middle ear anomalies and conductive hearing loss. And so it is it's a really big effort, not only surgically to do the microtia, but also, with the wound care afterwards and the coordination with the hearing. And so I do collaborate with our craniofacial clinic and plastic surgery for total auricular reconstruction, which is what you would need for most cases of microtia. Now, the landscape, it's a really interesting time because, my primary concern, especially early in life with the microtia kids, is the hearing. The goal is, and anyone who sees ear molding, you kind of have to identify, well, this is not moldable, and actually this is going down microtia pathway, and we have to get them plugged in. The goal is to identify any conductive hearing loss and get a soft band conduction hearing aid on by 6 months. Historically, the hearing reconstruction would be a canalplasty for stenosis or a tresioplasty for atresia. Now, I still offer canalplasty for stenosis and OCR if they are a good candidate. And I use kind of like a modification of the Jarsdorfer score. For me, it's really important to have that STAPES. Traditionally they teach us that the STAPES counts for 2 points in the Jarsdorfer score, but if there's no STAPES, it's a no-go for me. Without getting too much into that, I'll still offer the canalplasty for certain kids with stenosis and OCR for hearing. For atresioplasty is very controversial. Even there's a very high complication rate of creating a hole out of nothing and doing circumferential skin grafts that don't, necessarily can't self-clean itself, and it's like a lifetime commitment to seeing an otologist. And even the most experienced atresia surgeons, the best outcomes are expected to be still around a 20 to 30 decibel loss. And so now we're in an exciting time where we have these bone conduction implants. And so Ossia, made by Cochlear Corp, is right now the most popular bone conduction implant. And it recently, in the past couple of months, was FDA approved down to age 5, which is around the earliest time that you start thinking about doing a microtia reconstruction. There's also now a competitor on the market called Sentio, made by Oticon. Now, Oticon makes the Ponto hearing aid device, which is really popular because it has a huge range and great sound quality. And I understand they're doing FDA trials to approve the Sentio down to age 3. And so this is, a big game changer for atresia because it can give normal levels of hearing. And in the microtia world, historically, the hearing has come sort of during or after the auricular reconstruction. And even with these implants, it would still come during or after because monopolar cautery is contraindicated. So raising any sort of flap, you wouldn't want to do with an Ossia or a Sentio in, although there are some plastic surgeons out there that say they do, and it's fine, but it's not. It's just not. We're seeing those patients afterwards, and the devices are all wonky. So, but there are ways now to raise the flap, like with a harmonic scalpel blade, which is not monopolar cautery. And so it is an interesting time now that I'm sure we'll sort of see some groups try to implant before auricular reconstruction, but it is, a big coordinated effort. And then again, for the kids who have not isolated microtia, but if they do have very severe hemifacial microsomia and they'll need a mandible later, that's, something I collaborate with. That's plastics for us here. And so we have to make sure that we're not going to do anything with a hearing and putting an implant in if they're like, no, we're going to have to do this. We're going to have to do a mandible after. So there's no point in putting it in now. So being involved with the craniofacial clinic is important in some cases. Yeah.
Yeah, that's pretty cool. As we start to round things out, are there any recent advancements specific to ear molding or new therapies or techniques? You'd mentioned the different devices. It sounds like you've gotten gritty and creative with your own. I feel like you should patent your own in-office technique. But anything that's on the horizon for ear molding that's coming up?
Yeah, I think one thing moving forward, other than more otolaryngologists who see children sort of recognizing it and maybe starting to be able to integrate it into their practice, because this is something with an increasing demand. This is something that before people would. It's always been there. There just wasn't anything to be offered, but now we're in a new era. Families are really looking for it. Pediatricians now are looking for people to do it. And so as it becomes, more popular, it would be great if we could have, a CPT code or a way to sort of to reimburse this in a more streamlined way. And then I think on the education front, talking with other people who do this across the country and seeing the need and wanting to sort of share with our colleagues to sort of make this a more common practice. We're going to try to do, panels at our major meetings. There's even a very preliminary thought about now that we have like simulation and 3D models being very easily accessible, having like a newborn ear model just to practice applying the molds on, just because it could be sort of daunting to do it on your first patient. So those are some things that could be coming up. Yeah,
that's really exciting, Jason. Any final pearls for our listeners, or if anybody has any questions for you? Are you on any social media?
I have a private Instagram account, so don't have a professional social media, but people are welcome to email me at my UCSD email is what I use, jaq001@ucsd.edu, or you could slide into my personal Insta DMs, ZJasonQIAN on Instagram. So
awesome. Well, thank you so much. I learned so much, Jason, and I've loved getting to know you, and I can't wait to still continue to get to know you.
Yeah, absolutely. Thanks so much for having me. This was so fun, and we'll continue to sort of chat like this at the hospital. Yeah.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Qian Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.